Thank you. Good afternoon, everyone. I'm Greg Kirk, Vice Dean for Research. It's good to see a fair representation of the people who signed up actually filling seats in an auditorium, and looks like we have a large and growing number of participants online.
And the things change.
Excuse me, Kim Clay, could you mute yourself? For those of you that are online, we'd appreciate if you would mute yourself. We do want to make this a discussion, so as we go through the talk, we will be opening it up for questions and discussions. Welcome to a continuation of our series of discussions as part of PHAISE, the Public Health plus AI Strategic Endeavors. We started this initiative over a year ago. You may recall have seen or participated in several events over the past year. We had the big AI Research Day in the fall, and we are planning to have another Research Day. We had 33 posters, a keynote speaker. We've also intentionally asked each of the 10 departments to co-host a departmental seminar, sort of integrating their departmental foci of research together with an AI-related topic. And we've made it through half or so of those departments. And today we're very pleased that the Health Policy and Management Department agreed to co-host this PHAISE seminar. It's my pleasure to introduce Dr. Jonathan Weiner, who's going to really talk about his both historical perspective on doing AI and data analysis and predictive analytics before we used some of those terminologies. He's been at the school for a long time, did his DRPH here in the, I guess, was it called HPM or was it Health Services?
It has like 4 different names.
Yes, so it predated HPM as we know it today. He co-founded and, founded and is now currently the co-director of CFIT, the Center for Population Health Information Technology, which I think many of us recognize. He's very well recognized as being the co-developer and launching the ACG, the Adjusted Clinical Groups, which has been around for 30 years. It's we also are as part. I see Anthony Leung in the crowd, and we also, as part of the Research at BSPH initiative, we're having our Innovation Translation Council launch in May of this year. That's our commercialization innovation council that's going to be doing a lot of activities. Well, Jonathan was doing that a long time ago as well. And in terms of licensing and revenue that's come into the school over many years, probably the ACG has contributed about as much as any of our commercial related activities. So he's helped to lead doctoral programs. He's currently, I believe, serving on the faculty senate. As well as really being a leader in population health, healthcare, health informatics, many of the topics that you see on the news frequently today. So it's a big ask. We're asking Jonathan to really talk about how we can leverage AI and data science to improve population health. We do plan to have a lengthy opportunity for discussion. Do you want to take questions as you go, or do you want to save them to the end?
Mainly the end, but
okay.
Clarification always welcome.
All right, so we do have discussion time planned for the end. And without further ado, please join me in welcoming Jonathan to lead us in this discussion.
Thank you. I really appreciate everybody hear me okay and at home. I'm going to use the mobile mic and move around, and people at home don't really need to see me. You can see me once, and mainly just the slides. So Greg, thank you for that warm introduction, and more importantly, thanks for everything that you do, including this, the deans. We wouldn't have a school without the deans, and did I lose stuff? Still working, okay. And we won't have a future without AI and data science. So I'm pleased to participate in this. The PHAISE, make sure, did we, excuse me? There we go. So the talk today is indeed to try to put together this initiative, the PHAISE initiative, and here are the slides that I took off the webpage. PHAISE is really about, as a collective here at the Bloomberg School, thinking about data science and artificial intelligence. Of course, some of you in the room could give this presentation on what is AI and artificial intelligence and data science. And some of you say, huh, what is that? I know about ChatGPT. Is it something more? So I will not assume advanced knowledge on what is AI and data science, but we all know it's important. We all know it's our lifeblood, that is data. And of course, now it's a lot of things. But to foster in-depth discussion. We have 90 minutes together. I hope you guys can stay. I'm really grateful for those of you in person. I'm also grateful we have a very large number of people online. And please, we are monitoring the chat. Those of you online, please do make sure you're on mute. We're not killing your mics because we want to have interaction later, but please stay on mute. But if we're monitoring the chat, and if you can't hear, if you can't see, please let us know. And what we'll do is, my plan is to spend the first 50 minutes, certainly stopping by 1 o'clock Eastern. And then I'm still hearing a mic other than my own, I think. So I don't know. Do we know who that is?
We got it.
Okay. So, and then we'll have an interactive discussion, and I don't know if it's me that's supposed to turn off the mute, but I'll do the best I can. I won't worry about technology, but hybrid is always a challenge, but it's an important challenge because our school is very much hybrid. But we'll spend the last 35 minutes having a discussion where we focus on population health. I'll describe that, and it's not exactly synonymous with public health, but it's close. And healthcare systems. That will be our focus today, much like health policy management. So my goal for today, and a goal for all of us together, this will be interactive, is indeed to further PHAISE's objectives, as outlined on the previous slide. And here's again the previous slide: to foster in-depth discussion, to identify areas of future strategy, and to enhance the adoption of these schools as appropriate. And these aren't my goals, but they're good goals. I wish they were my goals, but they are my goals for today. But I'm going to do something else. I've been here a long time. In fact, I was talking to Greg that I started out my doctoral career in this room. It wasn't the Becton Dickinson room. This was the first auditorium. And other than the dean, who was a colleague of mine a year ahead of me, I've been here a very long time, and there are not many colleagues that have been here 47 years. But we were doing AI or something like AI 47 years ago. We didn't call it that. We were running things recursively again and again. It might have taken weeks and weeks. And I remember the IBM, I think it was IBM 370 in the basement of the Rutland garage, had about 1/10 of the power of the iPhone in your pocket. We've come a long way, baby, but still, we've been using this resource to further the health of populations. So that's what we'll be trying to do today. But we'll need to getting feedback.
Yeah, okay, that's it.
You think it's internal? That makes it worse.
It's large microphone.
Or should I just tell you what? Maybe I'll get rid of this mic. We're getting feedback.
Maybe just switch to.
I'll switch to this mic. Can people at home still hear me? I turned off the mobile mic, and yeah, so I'll just use one mic and I won't move around. Apologize, but we'll get over it. Again, technology always has its transition period. All right, but I am going to, is there a laser on this? I guess, no, I have to, can people see this move? Oh, no, it doesn't move. I'm trying. So I'll point. But I'm going to review the framework. So there's a shared agreement of what is artificial intelligence. By the way, I use the small I because for the first 3 years, whenever I put AI sans serif with the type, everybody said, who's Al? Al Somer, Al Wu? No, not Al, AI. So I always use the small AI, and at least people are clear that that's an I, not an L. And the data science, one thing that you'll see is no one agrees exactly what is AI and what is data science. So I will share with you some definitions. As I tell the students in my class, understand my definitions, you get extra credit for having a different one that's better. So there's nobody has a monopoly on a definition of AI. And that's another point. Developing the framework of what is AI and what do they say? Forming the narrative, owning the narrative. Computer scientists alone, God bless them, but don't own the narrative. It is something that is woven throughout the fabric of everything we do, therefore the narrative belongs to all of us. So that's some of my premise of what we'll talk about today. But I am going to focus on population health and healthcare as we do in health policy management. All right. What is health policy and management? A good number of you are in the department, but a good number of you aren't. It's one of the departments in the school. This came off the webpage. I didn't invent that. We advance evidence informed solutions to systemic public health challenges and train tomorrow's leading health administrators, advocates, policymakers, and researchers. And that's what we do. We focus on public health systems, but also medical care systems, healthcare systems. In fact, when I first came, the name of the department was Healthcare and Hospitals, or Medical Care and Hospitals. They kept changing the name again and again. And Health Services Administration, now it's Health Policy and Management. The #1 department, I think that came out today or yesterday from a magazine that's no longer here, but we won't, they won't care about that so much. As you know, there are a lot of research centers everywhere in the school, and we have many. I won't read them all, but if you go through the list, there's not one that doesn't use data or doesn't create data or doesn't talk about standards for data. But that's probably true in many cases, if not most cases, across the department. That just gives you a flavor. I formed and now co-direct with Hadi Karasi, who's here, the Center for Population Health IT. We use the term information technology because at that time, President Obama was sending out the door tens of billions of dollars to put electronic health records, EHRs, on every doctor's desk in America and every hospital in America. And now indeed we have it. And one of my premises, AI or not, it's incumbent on us in public health to make use of the digital data that currently exists everywhere in our healthcare system to help and improve lives instead of selling people stuff. The main premise with most AI today is to sell us stuff we don't use. That's what the big tech companies, I don't mean to be too cynical. I'm actually very supportive and enthusiast, somewhat evangelical on AI, but I'm also somewhat cynical. So what happens if you're in between? I don't know, a realist. I guess that makes me a realist. But if you look at the tech companies and the consultant companies that are promoting AI, it's really to sell their products. What is our product? Improving health and society. You know, an uphill battle nowadays, but again, something that we must take the data that we have. And again, President Obama, with his Meaningful Use project, did indeed, as many of you know, put EHRs on everybody's desk. Most of them cannot be used for public health today. Some of them can. So one of the premise, whether or not it's with AI or data science or just getting the system in place, that's one of the things we'll talk about. And that's how we first started our center, trying to make use of electronic health records. And I and colleagues, Don Steinwachs, Jerry Anderson, were one of the first in the country back in the 70s. Back in the 70s when, well, it was really in 80, we ran the data system. The Health Services Research Center, now the Cheshire Center, ran the data system for ambulatory care clinics around the health system because there were no computers for that purpose. So at that era, it was our goal to take advantage of administrative data and claims data for the purpose of population health. So that's a little bit of the history and where we came. So the ACG, some of you know a lot about it, some of you have never heard of it. My goal, secondary goal, is to have everyone in the health system should make use of ACGs if they care to. Most of you know about the World Health Organization's ICD codes, International Classification of Diseases. There are 100,000 ICD codes. Any patient can have any one of the 100,000 when they visit a doctor. What's 100,000 factorial? A lot of combinations. The Food and Drug Administration, yes, I think there is still a Food and Drug Administration. We look for good things from Dr. McCary, who's one of our colleagues. They have 100,000 different codes for pharmaceuticals. NDC codes, they're called, National Drug Codes. So one of the advances we made was to take all of these 100,000 factorial medications, 100,000 factorial drugs, with the help of recursive partitioning, which wasn't called AI at the time. We had groups of clinicians. We had a slow computer that looked at all the combinations and came up with these categorizations called ACGs. Today, ACGs are in use in 24 countries, 250 million patients every day. It's algorithms, it's predictions And we have a lot of experience, and also it brings in revenue to allow us to do public health. And many of the team are here or online. So that's a little bit. And if any of you are interested in using tools from ACGs, please let us know. All right, let's move. The context. We could talk about a lot of things. What is population health? What is population health? Population health is thinking about public health, thinking about populations. On the right-hand side, again, this mouse is not showing up, so I'd have to hold it. Maybe if I do this, swap screens. No, you don't want to do that, no. So how do I get out of this? Oh, I just have to go. I can't control it. Shouldn't have done that, sorry.
Okay, we'll just switch these over. Oops, I'm so sorry.
Okay,
Yeah.
technology. How many tech people does it take to, okay, you got it now.
Yes. Oh, I'm sorry. I think I did it wrong, actually. We want this here.
What happens when you have, sorry, people at home, I hit the wrong button, you know how that goes. Okay, that looks good, and
Is
I
that
won't
okay?
touch it.
Here's your mouse, and it'll
But
go this
it
way.
doesn't show, and that's okay, I'll live with it. Oh, you did it.
Yeah.
Thank you. Where is the mouse? The mouse is, all right, thank you. But I have to look up there, right? All right, I'll try to be, this side is, that's awkward. But this side is the, side of the community, the population. I won't bother doing that. It's not worth it. But thank you for figuring it out. So on the right-hand side, I'll talk it through. On the right-hand side is the population, is the community. And that is normally the focus of public health, and God bless public health. We care about the entire community. On the left-hand side is the healthcare system. The healthcare system cares about the people that walk in the door. Until recently, the Johns Hopkins Health System right across the street, literally across the street right here, focused only on the people that walked in the door. They didn't bring people in. That is shifting. Now, increasingly, when people say population health, and Josh Sharfstein, our dean and former health secretary of the state and former city health commissioner, said, Jonathan, population health is great, but it doesn't include everybody, so I don't really like it as much as I like public health. Something like that, he used to say. Because the provider organizations, unless they're focusing on the entire side, both sides of the equation, may miss some patients and may miss, for example, someone at risk for a condition and may not address the environmental. So population health informatics, the main focus of population health includes both the right side, the left side. It includes the system, the provider, the individual clinician, and the consumer. Clinical informatics, people that focus, and there are a lot of colleagues here doing great work at Johns Hopkins, on the doctor, the nurse, the patient. They care about the interaction. All of us care about the interaction, whether or not you're a patient or a clinician. Everyone's a patient. Some of you are clinicians. But you don't necessarily take into consideration the entire community, nor do you take into consideration the entire system. One thing about population health, one thing about CFIT is we focus on the entire picture. And we can talk a lot more about this, but I wanted to set that stage. This slide, which you saw a little bit before, this is the classic CDC. We still have a CDC, right? The CDC put this out, although it's been adapted, and we'll see what happens. But this is the classic public health wheel. Talks about assessment, talks about policy development, it talks about assurance, it talks about management, it talks about research, and here the specific components. There's nothing here in public health that you could possibly do without also taking into consideration data science, and analytics. So my premise with these first two slides is to sort of set the stage of what population health is, and classic public health, which focus at least historically on communities, not necessarily healthcare organizations, has these tasks that really are central to the Department of Health Policy Management, indeed the school. If you haven't heard of a learning health system, LHS, what that is brought to us by population-based organizations that deliver medical care, such as Kaiser Permanente, HMO, Health Maintenance Organization, or Managed Care, or now the Johns Hopkins Health System, headed by our colleague Scott Berkowitz, has a population health intervention trying to get clinicians think like population health providers. Indeed, At the top, you have outcomes, which is sometimes called the triple or quadruple aim. Then you have a base, and on that base, you see ethics, legal, policy, technology, which I haven't read, science, and social. I like this slide, but this is the classic learning health system, where you have knowledge management. What is knowledge management? Think ChatGPT, think large language models, think, will we ever use books again? I'm not sure. And how we take that, we learn, and then we have a loop that puts it into practice. So if you think about a learning health system, you're thinking at every phase, the use of knowledge, the use potentially of data science, and in some cases, AI. So my premise is when it comes to public health, when it comes to population health, when it comes to the new model of value-based integrated healthcare, data and AI is central, and health policy and management, and indeed the rest of the school is as well. We can't give a presentation at a school of public health or in health policy and management under the leadership of Keisha, the importance of social determinants, equity. Now the names are changing. I had a discussion the other day with a federal agency and used the word social determinant of health, and they said, Jonathan, you meant whole person health, didn't you? He says, yes, I meant whole person health. As long as we think about the person, not just based on their diagnosis, but also on the whole social facet. This is an excellent, if you haven't seen it before, an excellent framework that goes all the way from left to right about, we'll have to maybe change the terminology, but they're all important topics. Inequities, institutional inequities, living conditions, risky behaviors, actual disease and injury and mortality. If you focus on medical care, we're only down here, right? But so for those of you in the behavioral or those in health policy and management or elsewhere that are very sensitive to social determinants, there's nothing you can do here without data management, without analytics, and without using available data. Remember, when one understands social conditions, one is not usually talking about medical data. One is talking about social data, economic data. And you know that Google knows everything about all of us. You know that LexisNexis, for $5, they know the magazines you read. They know what web pages you've looked at. They know what products you buy at the store. Why don't we use that stuff to improve people's health, not to sell us stuff? So again, the data are already there. The techniques are there. The framework to do this is not always there. And so that's one of the challenges that we face. All right, looking at the clock, and there's a big clock right there, and my target is to stop with a half-an-hour discussion. By the way, if there is a brief point or if there's confusion, please raise your hand, please chat. Otherwise, the last half an hour will be a full interaction. So that's the plan. And again, we have about an hour and 5 minutes left. So, but the next phase, I want to give you a flavor for the stuff. I've given you a flavor already, but a more organized structured flavor of what we're doing at the Center for Population Health IT. We pronounce it CPHIT, C-P-H-I-T, or CPHIT. And we have 150 articles at this URL. By the way, we will put, I think the hope is to put this presentation or parts of it online, but the PDF with all the URLs will be also put online if that's something you do, or you can always contact me. So I have about 24 URLs that my goal as a professor is to teach. So if anybody, and I checked them, a lot of the federal URLs were taken down, so I found them or found private ones. So all the URLs worked an hour ago, or 2 hours ago. So I hope they work by tomorrow. So we'll see what happens. Okay, so real quickly, Elham Hatef is one of our colleagues who does a lot of work, as does Elise Lasser and Chintan Pandya. And Hadi Karasi, all of the team. We spend a lot of time extracting using natural language processing, NLP, also called text mining. Some people consider large language models in this category. We'll come back to that in a moment. But one takeaway message is an awful lot of the healthcare information is indeed just doctors, nurses, others typing. Increasingly, doctors hate electronic health records, as do nurses, as far as I know. And increasingly, ChatGPT listening into us. I mean, you know that right now, all of our phones are listening. And if you have an ALEXA device here, they're listening constantly. But they've turned it on to allow doctors and others just to listen what's happening between the patient and the doctor. But for now, they're typing. So the whole area of natural language processing and taking this amorphous information and making it something we can use is a very important domain. And when it comes to understanding social factors, social determinants of health, this is an area at CFIT where we've written about 15, 20 articles. How right now in the electronic health record, when you look, here's a study that we did, Hadi took the lead. We have a Venn diagram. This is electronic health record free text that we got through natural language process. So for example, this was a group of elderly people. The doctor or nurse put in the notes, all of this in green, and it is to scale. Social support, all of this is in green, was documented in the free text in the electronic health record. The blue is the electronic health record where the doctor or nurse clicked on an ICD code or clicked on a structured survey. And we also spend a lot of time with insurance records. You know, you go to the doctor, he or she writes something down, submits a bill to the insurance company, Blue Cross or EHP. EHP has a record of what happened. So that's the claims record. By the way, an important point. Anybody that does a study with an electronic health record, you only have the information from that one provider or that provider system on that patient. If the patient gets care elsewhere, it's missing. So that's a big important point and why we often use claims data. So look at this. What are some examples? These different conditions focusing on elderly. The blue was the structured EHR, the orange was the non-structured EHR, and the green was the free text. So my main point is data everywhere, but it's not always concordant. But without the natural language processing, we wouldn't have much. So that is one of the studies that we've done. Again, ACGs, adjusted clinical groups, I already talked about that. I've already mentioned this. If anyone needs the URL, there it is. It brings in money to support research. It is one of the biggest, if not the biggest, technology transfer in terms of bringing in resources. It is particularly in these budgetary times important, but more important than the money is we impact 250 million patients every day, every week. I know that most of us are happy and impressed when we get 10 citations or 50 citations or 1,000 citations, but that's different than having the impact that we do. And this in the slides, I'm not going to read it. There are 300, if you input ICD codes and NDC pharmacy codes, you get 300 variables come out that our clinicians and our AI and other analytic techniques use. And we also benchmark, we develop predictive models. So if you just put in JHU ACG or get a hold of these slides and we make the software, it does cost commercial concerns, but we make it available to academics for free and Medicaid agencies, et cetera. We also, one thing I want to highlight, if you think about 100,000 factorial times 100,000 factorial, that's a lot of combinations, isn't it? So humans have all kinds of different combinations of disease. Using clinical input and using decision data science, we took everybody and put them in only 11 segments, 11 categories. So when giving population health, yes, it's true. So the concept of precision medicine is an interesting one. If no two patients are alike, how do you give public health? How do you give population health? Yes, we do need to be sensitive to the fact that no two of us are alike. That's true. But on the other hand, if you're running a healthcare system or if you're trying to provide prioritized services, well, maybe 11 categories are good enough, or maybe 15 categories. The National Health Service in the UK that thinks like that is using this very heavily, as are many HMOs and other organizations. So these show the patterns, high complexity patients, people with a dominant psychiatric condition, and it's by age. And we also have low complexity. And so if any of you are, we also capture frailty in the case of elders or non-elders. So again, this is just, but it is an example of our application of clinical combined with data science to scale, because this is actually used. We have 12,000 articles. We only contributed about 2,000 of those. but the other 10,000 are people all over the world. So we're very gratified. But this is actually used and applied. Another important point we'll get to in a moment is explainability. Someone will say, well, Jonathan, why do you only have 11 categories? Well, if you have to explain it to 20,000 doctors in the UK and nurses and administrators, you may not want to use deep neural nets. And the AI may be 3% or 5% better than only 11 parsimonious categories. So that's a long discussion and something I've learned. The trade-offs involved in the full bore AI, are they worth it? Sometimes yes, sometimes you don't have to explain it. Sometimes you need to. All right, moving ahead, I'll just jump over this. We are also making use of, in the electronic health record, doctors work very hard and other clinicians putting in vital records. Those records are not used in population health. It's very difficult to do. I remember Hadi Karasi, who's a 11 on a 10-point scale in terms of working with data. What did it take you, Hadi? It took you 2 months to figure out the BMI data for the VA records. So it is not easy because the stuff is not ready for prime time. And you might say, oh, we'll just let the AI figure it out. The AI, if you give it inaccurate data, you will get an inaccurate analysis or biased analysis, which we'll talk about. What if the BMI is better for certain racial groups or in certain parts of the country, and you ignore that? So there's many issues that AI alone can't handle. But that's one of the challenges when using clinical data. Increasingly, what's happening, because the doctors and others want to use the data, they use what's available. They have a great recent master's student who knows how to use one of the software packages. They press a button and out comes a prediction, ROC or the modern equivalents, F1s or whatever. And it is actually pretty good prediction, but it includes all types of things that you would have flunked Epi 1 for, or Econ 101 for, or Intro to Medical School 101, because clinically you've made some assumptions. So the trick is how we can take the analytic and combine it with all these other skills that everybody in the room has spent many years learning. All right, let's move to the next part of the talk. This is a sad but important study, and also a highlight that data everywhere, but not a drop to drink. A very important and sad project. Maryland at the time was the number one. I think we're still pretty close to the top of opioid overdoses, both fatal and non-fatal. And we were asked to do a project where we linked in data, a classic public health project, data from the medical examiner, criminal records on drug possession and sales, mental health and substance abuse, and methadone. We have, some of you know, an all-payer payment system that indeed we have some of the best data on healthcare in the country. And we took this to focus on how we could understand and predict opioid overdoses with a broad team here at the school. Very important project. And the data exists. The political challenges and technical challenges were the political challenges were greater than the technical challenges. And we developed models to try to identify people at risk and people that needed intervention, a classic public health approach. The data were there, and we did use advanced analytic approaches. And yes, that was important. And yes, we could tweak the models a little bit more with various machine learning. But the focus just on that and not all of this, and not, it's great having a score. What are you going to do with the score? I don't need to tell many of you who are expert on this challenging area, the social and political and legal implications of trying to lead to change with that AI-based system. Much harder than developing the actual model. All right, so looking at the clock, I'm doing all right. So I've been using the term artificial intelligence, machine learning, natural language processing, large language models. I've used the term predictive analytics. I'm not sure I use the term big data. It used to be the hot term. Big data and AI are not exactly synonymous. Nobody uses the term the same way. This cloud comparison, if you think about your favorite term, it's here somewhere. data science is not the same as artificial intelligence, but I would say, it includes, technically econometrics is not AI. Biostatistics is not AI. But increasingly, econometrics and biostatistics does use, indeed, artificial intelligence and machine learning. Where is the line? Like many other taxonomies and classifications, doesn't matter. Well, sometimes yes, sometimes no. But one point I wanted to make is, and actually not, this is somewhat wrong, everybody would do a little bit different. Not all natural language processing is technically AI, but all natural language processing is probably data science. We could spend, with 5 experts, we could spend an hour talking about this and no two would agree. So what? The so what is that there is confusion. And as I tell my students in class, understand my definitions, understand your definitions, understand how people use it, right and wrong, because when they communicate. So today, when people say AI, I'll show you in a moment. I go, to a sports event or a party or something, and I use the word AI, and 5 people think you mean 5 different things. And even among professionals talking about analytics, there's even not full agreement. So it doesn't completely matter. By the way, all of these are URLs, and when you get the slides, hopefully it will help you. But data science indeed is the application of analytic technique. Much of the data science is artificial intelligence, not all of it. Machine learning is technically a subset. And let me give you just a few working definitions, but just be cautious and never take anyone, nobody has a monopoly on the definition. Yes, of course, someone that says they invented the term. A lot of the terms were invented by consultants at IBM and others that wanted to sell new products, or now increasingly, what do they call them? The tech bros, the guys, the gifted, rich guys who now own the AI engines. They have certain agenda. Some of them perhaps good for the rest of us. Some of them definitely not good for the rest of us. And should they own the term? Well, they certainly own data centers where the AI is being run. But all right, let's continue. So because it's so common nowadays, the chat GPT, the generative AI, and everyone talks about the large language models. This was, I think, reputable. I've tried to talk to people and people say, yeah, it's sort of right. But large language models indeed are the shared space. Yes, it's deep learning. I'll talk about that more in a moment. Deep learning is brute force, where the computers that use up a gallon of water for every analysis, you know about that? You know that these data hubs need to be cooled down, and these analyses are so hot that sometimes they literally have to take water to cool down the machines. Read up the environmental impact of AI. I'm not making this stuff up. But because of the deep learning brute force, it is in this sort of intersection between NLP, because it's looking for unstructured data. Not everybody agrees with this, and I wouldn't presume to say, no, you're wrong and I'm right. But this is a reputable definition. So when you think large language models, yes, think machine learning. Yes, think a deep neural net, brute force type of approach. And yes, in general, think about using data that is unstructured. Indeed, you can use it for structured data, but in general, I view it as an advanced. I made fun of the Department of Health and Human Services 5 years ago when they had a chief AI officer. I don't make fun of him anymore, and I hope she survived the budget cut. Yes?
Can you explain the difference between machine learning versus...
I'm going to get there in a second. Good question. And there's others in the room that might do a better job, but let me make a first attempt. But there is indeed a U.S. Department of HHS Office of AI, and this is their definition, okay? AI enables computer systems to perform tasks normally requiring human intelligence, okay? It's one definition, but it's basically when the computer, the end result is it accomplishes something we wouldn't have done otherwise. All right. Machine learning is a type of AI that gives computers the ability to learn without being programmed by humans. And I'll get to your specific question in a moment. So this is, some of you have seen this before. Well, let me do it one at a time. So if I'm in a room and someone says, boy, Jonathan, AI is really going to have a big impact on my clinical specialty or my management area or my analytic area, they mean one of four things that overlap but are really sort of different. So let's do them one at a time. The biggest right now is the generative AI, and I don't mean developing funny pictures of dogs or a fake movie of the president or a senator, although that's generative because it generates something new. What I do mean is I think I've heard that if you give the medical physician test, the first level, to ChatGPT, it'll pass it at a rate pretty much similar to many medical schools. So the concept of all of us clinicians and non-clinicians memorizing things that may or may not be a thing of the past, we'll see. But for sure, we've all used ChatGPT. The ChatGPT that we use is for free is level 1 of 5 levels. You know, you can pay a lot more. And I don't claim to be an expert on that. And we all together need to think about what that means. But basically, it is taking knowledge that exists and synthesizing that knowledge in such a way that it's useful to you. And we need a separate talk on that. And the rest of my talk and my talk so far is not focusing on that so much. But when I'm in a healthcare organization and they tell me, boy, I'm saving a lot of money using AI. I say, is it really AI? No, it's automation. Rather than talking to a human, you talk to a telephone or a computer or a chatbot. Rather than a nurse looking at your insurance bill, the AI is looking at your diagnoses and seeing if indeed it's the right diagnoses to cover that medication or cover that visit to the specialist. And that is huge. And yes, that has implications for health policy and management and the rest of us. It's not exactly what many of us do on a day-to-day. This is actually the source of 85% of all the Food and Drug Administration, FDA's approval of AI. And yes, AI interventions have to be approved by the FDA, are in this space. And although I'm not an expert on it, I want to acknowledge it. And that's the robotics, the sensing, the interaction of the computer with the world. And what does this mean? For eye exam fundi, for breast exams, for all types of exams, the radiologist comes in second after the AI, or the ophthalmologist, after the AI takes a look at the scan. And in most cases, it does as good or a better job. Increasingly, the whole robotics, the whole sensing, the hearing, that is going to be a huge area. Is that going to impact public health? Probably. But to me, the biggest area is the one I've already talked about. Data everywhere. How do we look for patterns? How do we do research? Do we need an RCT anymore? How do we apply public health? There's 2 million people in my community. I can't send a nurse in to intervene for all people with diabetes. How do I pick the 2,000 patients that need my help the most? For that type of big data analysis, the often called predictive analytics, the taking the data, if you are in a clinic and you're trying to predict who's going to have a bad outcome, who needs this medication, that's the one that nobody would argue is front and center today for public health, and the one that I'll talk about for the rest of the talk. Am I saying these other applications don't have any implications? I'm not saying that. But I believe, first of all, it's the one I understand the most and we worked in the most, and the one that comes closest to our current use of data within public health context. I would look forward when we have a discussion how these other three apply. And do they overlap? Yes, they do, but they are different. And by the way, many people confuse AI for all of this. Many of these things include AI, but automation, you know, the AI is only 5% of it. Having the data, applying the data, developing the processes is probably even bigger. And likewise, doing the predictive modeling, so much of it is not AI. It's good econometrics, it's good biostatistics, it's good epidemiology, it's good health services research. Yes, indeed, we need a computer scientist or informaticist with advanced analytic skills to help with some of the machine learning, but that's only 5 or 10% of it. That's my premise. All right, let's keep going. That's the point I just made, that indeed you can't, in the big data domain, it is a team sport. It's not just the computer scientist, it's him or her with all these other types of applications. I once said, gee, AI is the icing on the cake or the tip of the iceberg. So someone found me some graphics. AI is the icing on the cake. It's not the whole cake. When thinking about predictive modeling, AI is the tip of the iceberg. So those are the examples. I gave a YouTube talk that talks about this theme and this point I'm making, that AI is just a piece of it. Now you were asking, Anthony, about the different types of AI. This attempts to, there's supervised, where you tell the machine, you should do this, you shouldn't do that. This is all considered machine learning. So what machine learning means, and it certainly can be considered AI, is the machine learns from itself or learns from the process. And by doing a run, when you do a run that isn't machine learning, a standard econometrics, you just do it once, it gives you an answer. The machine, it helps you, but it's not like the machine recursively does it again and again and again until it gets better. Well, not exactly, maybe. In some cases, the machine does try different fits to the model. That could be considered machine learning. I'm not the one to give the second level presentation, but all of these, the supervised and unsupervised, that I can clarify. Supervised, which is my favorite, is where you have subject matter experts, SMEs, and people that really understand the data, informaticists, clinicians, healthcare experts. They work with the analysts and try to supervise. And for example, my favorite is there are 100,000 ICD codes. You have a non-clinical 21-year-old, very smart computer scientist who presses a button and takes all 100,000 ICD codes and gets a hodgepodge of different clinical areas. It may predict something, but you have that computer person along with a team of doctors and nurses who come up with categories that make sense and try alternative. That would be supervised, where the computer gives you suggestions. Unsupervised is you give the computer characteristics of what you're looking for, and it does it on its own. That's sometimes called recursive because it goes again and again. I could keep on going, and I'm the wrong one to present it. I would recommend this reading, and I'll send you the slides. But we'll continue to have that discussion later if you'd like. Deep learning, most of you have heard of that, sometimes called neural networks. Neural because it looks like the brain, and that's why we're so smart, artificially or otherwise. This is the input layer. This is the final outcome. The point is there's a lot of things in between that help us, and this is the brute force. So it would look at sometimes called, these are sometimes called features, not my favorite term. That's what computer scientists call the things that you analyze in an artificial intelligence. And indeed, they would tell you that we might just include 1 and 2, looking for correlations, or maybe a couple. But by including all of these, the model would have better explanatory power and better predictive power. So again, when someone talks about a neural net, there's various levels of this. And again, I'm not the one to present it, but this for sure is artificial intelligence. Let's, one other point before we move to closure and then a discussion. We have time check, 40 minutes left. Hopefully people can stay. Yes, indeed, some of these machine learning techniques are pretty good, but an important point. Machine learning and AI applied badly is definitely not better than other advanced analytic non-AI techniques applied well. And indeed, when in looking at raw evidence about when is a model better without bias, part of the other problem is bias. You all understand there could be good studies and bad studies in the epidemiologic or economic or health services research domain or any domain. Likewise, there's bad applications of AI or good applications of AI. But a very interesting study right here, it was early on in the days of AI, a systematic review of 282 different clinical predictions where bias was taken into consideration. The LR favoring logistic regression favoring machine learning. Some types of regression can indeed be AI. This was standard regression that wasn't an AI type of technique. The main point is this AUC were better for the machine learning. This AUC for the regression, the non-AI. And when you had bias, very often the AI was better. So the premise, the takeaway is you cannot always assume AI is better. Sometimes it is. Sometimes it is. And so before any of you that ever tried AI or any of you that ever tried to make sense of someone else's AI will appreciate that AI is not without cost. And any type of predictive analysis, any type of analytic approach, indeed has negative aspects to it, which we'll move to in a moment as we move to the discussion. All right, I think I've made my main points. So let's shift gears and talk a little bit about some of the downsides, and then we'll move toward the discussion part of the meeting today. So this was a great paper in the British Medical Journal, BMJ. I think the title of the paper was AI stands for Augmenting Inequality. So some of you may have heard Ziad Obermeyer's talk and other presenters, Khadija Ferryman, a colleague in health policy management in the Berman Ethics Institute, spends a lot of time talking about all the damage that can be done through AI, through bias and other types of issues. There's all types of ways that AI can cause harm. But for example, if you have a database that doesn't include a certain racial group, or a database that doesn't include certain types of data that are missing, and you do a run, and that then becomes the model for all clinicians or all organizations, you are taking that harm and you're setting it in concrete. And I've never seen a project where that wasn't potentially the case. As you know, no study is perfect. Certainly no AI is perfect. And particularly nowadays, much of the AI is done by a small team, not taking all of the considerations that one would normally take in before setting standards and guidelines. It's really just people that understand the neural nets, and I'm not one of them, for example. And so all of us need to develop at least an understanding enough to collaborate with colleagues, just like we have a team made up of other colleagues. You don't have to understand everything that they do, but we need to communicate with each other so that the techniques can be appropriately used. And again, this was the AI office in HHS. I think it still exists. They had a very nice, they called it the Trustworthy AI Playbook. It's not just about bias, it's also about being fair, transparent, accountability, secure, because how would you like all of your predictive scores out in the open? So for example, if you have scores which are sometimes done in organizations, does that lead to ethical issues? So there's a whole slew, many of them new, some of them old, that we need to consider. I want to shout out to the Armstrong Institute, also AI, a different AI, along with CFIT, did a study for AHRQ, which was an agency that was closed down and merged with another agency, ASPE. But this is a study where both for AI and other types of e-health, we developed a monograph, and I'm pleased that it's back up. It was down, but it's back up I checked this morning, of how we should think about equity and challenges, both in AI and in e-health in general. So all of us, whatever we do, we may have to do it differently, need to take that into consideration. I encourage everybody to think about whatever digital or AI application you do, how this can be a tool for increasing equity or whole person health, if we're going to call it that now. And this is a very important area for health policy management. In fact, one of our chair's highest priorities. All right, so looking at the clock, I have put together a series of suggestions, okay, whether or not they're caveats, and there's caveats on it and anything. The more you learn about it, the more you see challenges, but the more you also see opportunities. I've prepared a series of ideas for moving forward. Yes, it focuses a little bit on HPM, but I'd say 50%, 60% apply beyond health policy management. Yes, it focuses on population health, again, which is the linkage of public health and healthcare. And we do more things in the school. But Greg, this is the part where, although I do have slides, open discussion is good. I'm not sure whether or not to.
Start?
Should I start and let?
Free discussion.
Okay. So basically, I'm opening things that I'm interested in hearing people agree, and I'm particularly interested in people disagreeing. It's sort of hard until we go through them all, but however we want to do it, we have a microphone for people here. As I go through them, I assume the people at home, and there's still a good number of you. If you have a comment, probably don't call me on missing things yet because you haven't seen all the slides, but if you don't like what you see, say something. All right, let's just go. So challenges and opportunity relevant to HPM. So the first point is that whatever is developed in AI, the constructs, that is how we apply it, how it makes sense, the framework has to work within public health, has to work within health policy, has to be something that fits our constructs. I'm not saying we can't be innovative, we can't start over again. The second point, so at any time, just feel free to raise your hand. By the way, we'll also have some open space where you can make comments on anything. But for now, let's stick to the points here. So I'll keep on going through, and we're monitoring, we'll monitor the chat, and we'll also monitor the raising the hands. And as before, all of these slides will be made available and we'll record it. The second is, I've already made the point, it's not just about the analytics, but garbage in, garbage out. We have to spend time on understanding the data. We have to work with the sources of data. We have to be concerned with biases in the data, inaccuracies of the data. My favorite is when someone said, look, all of the patients, blah, 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 from this geographic area aren't seeking specialists. So I guess they don't need the specialists as well. They're not in that database, they're in a different database. So if you do AI just with that data, it's not going to make any sense. So we need to spend time on that point. We should be experts here at the School of Public Health on the population applications of the electronic health record. We've always been collaborators with the clinicians on the clinical aspect, but that is probably the biggest new underused source of information. And right now, because of legal reasons, the people at the School of Public Health have very difficult time accessing the electronic health record, unless you're also a clinician. But you can't get access to it as a professor of public health. You can as a professor of medicine or whatever. So your point.
No, I was going to say like that when I took this job 5 years ago, as a clinician, I was like, let's put public health in the covered entity. And now that you assume a different role, you understand some of the rationales why that is actually pretty complicated. I did have a question, Jonathan,
Sure,
about the first two. You know, a lot of what you're talking about in those is the nuts and bolts of data collection and management, you know, basic epi. It often takes students longer to get their data set to a clean, analyzable state than it does to actually do and perform some of the analyses. So I think that's there's a lot of people that do this work that don't have that epi or, you know, essential training. So it's a twofold question. What do we do to help educate the broader population of the 20-year-old person just pressing the buttons to recognize the need for this? And perhaps more importantly, what is the cross-training that's required to be a public health specialist in this field?
Yeah, I don't have an easy answer. It's a good
They're
question.
not easy.
Not easy. Well, first of all, we do need to make it as easy as possible and collaborate together. And also there are AI tools that will assist in this process. So, you know, sort of a indicator of how clean the data are. So when my team looks
We're
at.
going to trust AI to confirm.
Oh, but it could be part of the process. I don't have an easy answer. I don't know if any of other colleagues, and there's several informatics type people in the room that might have I don't know, Hadi or anybody want to answer Greg's question, or Tom?
I think there's a lot of recognition within our own university. There's push and pull from engineering and medicine and public health about who's going to solve this problem. And I think what you're advocating for is that we all work together.
Absolutely, positive.
And I think most have agree with that, but that's not always what actually transpires on a day-to-day basis. Other comments from the crowd about training and collaboration? All right. Any thoughts about the EHR component? Yes.
Thank you for asking that. My question, mixture of a comment and a question, kind of touches on all three on this slide. Early in your presentation, you had a slide with a whole bunch of circles, and the green bit on the circles indicated the free text and doctor and nurse consultations that don't get gripped up into these tools and the analytics. If we are going to take a whole person and a public health approach to AI-driven healthcare or AI-informed enhanced healthcare, we have a wide range of health professionals that aren't even picked up by that. Speech language therapists, physiotherapists, pharmacists, clinical medicines optimization services, which is different to the pharmacy codes because they're actually pharmaceutical codes for pharmaceutical spending. And a lot of those are not only not picked up by the EHR process, they're also a bit of a double whammy. They tend to be free text. So is there work going on in that space? And if there isn't, how do we start joining those dots?
Great question. And again, I don't have all the answers. The good news is every one of those professions we've tried to show examples of how things would be better if it were joined together. And at least in an integrated delivery system, a Kaiser Permanente or Johns Hopkins on a good day, indeed, the input of all of those specialties, the PharmDs, the physical therapists, the social workers, are indeed increasingly in the electronic health record. Although there are challenges, I get care for 3 or 4 different organizations, so my data are across 3 different EHRs. And so that's one challenge. The other challenge, as you mentioned, there are different types. There's free text, and a lot of the things that matter for us aren't in anybody's EHR, because even the sickest person with 15 diagnoses, by the way, the average person on Medicare over 65 has 13 different diagnoses. And that's only half the things that could be diagnosable. So we need to rethink how we capture information, as you're suggesting. Did someone have a question, or I heard the mic? No? But go ahead, other questions.
Why don't we go on to the next slide?
Okay, let's go on to the next slide. And would you like to slide up when you ask your question? Go ahead.
Jonathan, you bring an interesting point that I now realize, that everyone may have, certain people will have access of data, but this data are incomplete in a sense that need a curator to further enhance it in order to go for analytics. So my question is, say, if we want to move into the innovation translation, there should be a company, or like there should be some assets about from a company point of view. From what point is from the data to the usable one? How challenging from your ACG experience to take advantage of the available data to become something useful for a business model?
A good question. We started with data that was 20 times worse, and we didn't stop us from getting started. As the data gets better, by the way, the best way to show flaws in the data is analyze it. And our ACGs are often used to pay doctors or to tell a doctor or a hospital who's efficient, inefficient, and what clinician or organization wants to look bad. So the first thing they say is the data are wrong. So that helps improve the data. So that's part of the answer. It doesn't mean that we should not get started. The other is that I'm not saying that you can't use these techniques with poor data. It just is a source of bias. So that's another point. But yes, improving the data and also getting access to data. That's why we need lawyers and policymakers and others. In general, 20 times the data that we currently have is available. And the last comment I want to make is everybody on the room and online, you all care about different things in public health or clinical or whatever your areas of expertise are. And whatever it is that you're interested in, the data situation is only 5% or 20% of the way to the final destination. So my point is if I were to think back 20 years of the data we had, it was only 5% of where we are today. And likewise, so you got to get started somewhere, own it, improve it, be the #1 on the US News and World Report AI quotient when they have that. They probably have that. I'm joking, but seriously. We can't pick a million things. One of the slides I have says we have to prioritize. So that's the best I can do with that response. And I'm glad to talk further. And the other challenge, which I thought you were getting at, is when we develop that, should that be proprietary? And how do we do tech transfer? It's challenging. So we've tried to balance making things available and transparent, but we didn't put it in the public domain. So how do we do that? But shared data and shared tools should be something that is universal, at least in part. Again, looking at the clock, we have about 20 minutes.
We have a comment in the chat,
Please.
which I can read out loud, and then we have a hand raised from Get Weary. From a healthcare background, we had a all hands on meeting to initially build relationships with cross-functional groups, then have technology governance committees to ensure the data are filtered through adequately. There's nuances with it, and it takes time. So that's a comment. Thank you.
Yeah.
To respond to that.
Yeah, I thanks for that comment. I don't know what to say. Everything takes time, so we've got to prioritize. And again, most data issues are very sensitive in organizations for many reasons, including the fact that things aren't working smoothly in many organizations today. Hands up. So let the person ask a question then.
Hi, thanks for a great talk.
Thank you.
There are obviously a lot of potential benefits, particularly for patients and payers, whether they're insurance companies and the government that pays for Medicare and Medicaid, to use AI to improve health of especially high utilizers of healthcare services. Now, assuming, not capitation, but most of healthcare now is fee for service, how can hospital systems and physicians leverage AI to improve health while not sacrificing their revenue streams? Are there any real life examples or even theoretical examples where you could see clinicians improving outcomes and the top and bottom line for their business?
Good question. How many hours or how many days do you have for that discussion? I think that we've got to prioritize. AI isn't magic. What was it that BASF company used to say? We don't make the product, we make the product better. So AI doesn't make the intervention, it potentially makes the intervention better. Good data, understanding the value proposition, understanding how, let's say, predictive analytics or a ChatGPT or an automation improves. You don't need an AI assessment of whether or not it'll improve value or quality or cost. You need a health policy and management or population health assessment. And then you need to show how if you really mean AI, the machine learning, the deep neural nets or LLM models makes that application better. So that's the best I can do. And the other problem is it for the doctor? Is it for the patient? Is it for the insurance company? Is it for the government? The economists will tell you that it really depends on whose balance sheet it is. So I'd look forward to continuing the dialogue. But that's a good example of how any challenging application, and what you said is squarely in the domain of health policy and management, needs to talk about the context and the framework, not just the machine learning tool. So thank you for that question.
What's the level of evidence, Jonathan, that should be expected? The questioner has developed a score to predict hospital readmissions. I'm got a health system. It's got a score.
Yeah.
He's done it on 100 people. It seems to work. Should we implement it? Do we need a full randomized trial?
The good news is there are many predictive modelers that have started to develop frameworks, Tripod and other types of things. And I would premise to you, it's not just empirical. It's also ethical explainability. And I would also suggest to you is that, if you develop a model that isn't transparent compared to one that is, and is 3% better, is that worth it? So I don't have the answer, but yes, by the way, on my list is frameworks, standards, just like, here at Johns Hopkins, we develop tools that others use to assess instruments or assess clinical interventions. We probably should do that in this space. But the good news is that at least for the predictive modeling, where you take patients, you take information, you try to predict an outcomes like hospitalization or death, or who's going to have advanced diabetes, there are criteria.
Yes. Then again, there's the commercial motivation to just get it into the medical record, just to get it to get the app downloaded. That they may not, the business officer for the company may not be so worried about the framework.
And that's why the welcome to America and the market, and we've succeeded and we look for it, but there's also trade-offs, and it shouldn't be. There needs to be checks and balances, and some things should be done on a collective, not by corporations. So on the other hand, we want the corporate innovation. We just can't trust them to determine when the product is better or not. Should keep going, and also anyone at home, please continue.
There is another question in the chat from
Ask it.
a Lashima Bar, and they do offer some context as well. What roles would one look for to be that crosswalk or translator for AI in population health? I am a soon-to-be MPH graduate with a background in clinical laboratory, healthcare, and community engagement, and currently working with the Quality Improvement Department of a health plan reviewing EHR for HEDIS.
HEDIS is a quality report card that's very wide scale for people that don't know it, and organizations get money or get fired based on the HEDIS, it's called.
They close out, I desire to be that translator and help ensure the proper use of AI in population health.
The most important thing is you have a degree in epidemiology. I mean, yours, training in epidemiology, not AI, that you understand healthcare systems, and you're conversant on a good data and bad data, and you can hold your own in a discussion with an expert on AI. By the way, everybody needs one of 3 levels of training in AI and machine learning and data science. We need to know how to use it as a tool. I can't code in HTML, but I know how to use internet, and I know how to work with people smarter than I when they're using various tools. So you need to be a user of other people's skill set and know the basics and when to use approach 1 or approach 2, or when it meets the standard or doesn't. Then we need leaders on our team who can actually apply the techniques in an operational basis. Then, as the Johns Hopkins University, we need to be leaders for the field in the country. So 1, 2, 3. It's not just for AI. There are 3 levels of training, and we should, when it comes to education, we should be thinking about all 3 of those levels. Everybody needs a basic. Some of us will be team leaders, subject matter experts, and others will shape the field. And so that person should at least have the first level, and it's a discussion that will be a longer discussion than just this one. So thank you for that.
Getting that hands-on experience, as she mentioned, of going through EHRs and community engagement, acquiring the basic skills, I think, is critical to whatever she may pursue later.
I want to quickly, was there any hands in the room here? I want to quickly, the last slides that I've prepared, and again, I want to share these slides with everybody, is just the first things, one I just said. We all need a basic understanding. Some will be subject matter experts, and a place like Johns Hopkins, we need to shape the field. And so we need to increase, the first one is increase our educational offerings. And we're at a decent place. We have in biostatistics, there's a lot in precision medicine. We have a certificate in informatics. We have a doctor of public health and health policy management informatics. Our colleagues at BIDS, biomedical informatics and data science. There is another important point. The clinicians and biologists in the room remember in biology or physiology 101, afferent and efferent, to and away. So we can impact to the field of AI, but even if we do nothing, it is going to impact us. So everything that we do in public health and in healthcare and beyond, even if we decide we're not going to touch it, we're going to be a Luddite, an AI Luddite, it's going to impact us. So we need to understand, and therefore it'll go in bidirectional. So that was just something that I think we need to be sensitive to. I also think that we can't forget, it's come up already, the bottom is probably more important. The top are some specific health policy and management. I hope to share this with my HPM colleagues, things we do in HPM. At the bottom, we do research, we do advocacy, dissemination, policy that isn't exactly research. We teach, we develop tools. By the way, in this field, it's not just teaching, it's developing tools. What's the medical adage? See one, do one, teach one. In public health and analytics, it's do one, program one, and then distribute 2 million. So this concept of that we need to develop things, we need to evaluate it, and then we need to disseminate it. I think the tools will be very important, and that's what the last one says. So why don't I leave this up and have people respond, ask questions. We have about 12 more minutes.
We do have another question in the chat.
Go ahead.
From Amelia Stedman. What are your thoughts on individuals who might use AI to replace answer seeking in traditional healthcare settings? Do the risks of misinformation outweigh the benefits of easy access?
That's a really good question, and one that I don't claim to be an expert on, but we have a lot of colleagues, maybe they're at the medical school, but also in health and behavior, and some in HPM. The whole issue of the role of the consumer or the patient, if that's what she meant, engagement. What do they talk about? Dr. Google? How many of us, particularly educated people, go to Google first before we ask our clinician, those of us that aren't clinicians? The ChatGPT has indeed but by the way, there's a whole, it's called New England, NEJM AI, Nature Digital, and JAMA doesn't have its own AI. They decided to brand all of their JAMA journals as having an AI umbrella. And so increasingly, these journals have had some studies that compared and contrast more of a clinical, one doctor, one clinic perspective. If I'm a patient and I go to see my doctor for whatever pains me, and I ask, not Dr. Google, Dr. ChatGPT, the Dr. ChatGPT in many cases is as good, and I even saw one study that I laughed at. It was more sensitive than the doctor was. So, oh, I'm sorry to hear about your pain in your back. So I don't have the answer, but increasingly when I talk about that first quadrant of AI, this is perhaps among most consumers, not public health people in HPM, but most consumers, the one that they're most interested in. You know, can I trust, should I use this supplement? Is that pain a heart attack? Does my mother need to go see a specialist, or my daughter, or whatever? So I don't have the answer. Should our school be involved? Yes, it should. You'd also think that the nursing and medical school will be as, if not more important on that. So that's the best I can answer. Now, if you ask, is ChatGPT and knowledge management going to be important to us as public health or population health professionals? Probably. And we need to think about the students in medical school and nursing school, yes, but how about public health school? Do we need to learn differently? Because I don't need to remember what was in my textbook quite as much. I need to know how to ask the questions. In fact, the role of doctors and clinicians in the future is going to be very different. Those of you that are clinicians know you have a left brain and a right brain like the rest of us, but you use the two sides of the brain differently. They say the surgeon's better on one side of his or her brain and the psychiatrist on the other. The side of the brain that's going to compete with the computer is not going to do very well, because the ChatGPT is always going to be smarter than your quantitative side of the brain. So good question in public health, and go for it if you have another question.
I like what you mentioned about that two developments and then distribute millions at a time. So I also see that you have two developments, tech transfer. at what point you think that the two developments should be going to the commercialization side? And also, does the commercialization side affect or bolster the millions concept?
A tough issue, one that we've walked a path. It's been a balanced path, not a perfect path. I don't have all the answers. Some things clearly need to, by the way, development and dissemination and tech transfer and public space is not mutually exclusive, but it is a balancing act. And in public health, we probably care about the balancing act more than would a colleague, with all due respect, at a business school or an engineering school. And I don't have all the answers, but I think that any tech committee like yours does need to be sensitive to what we can make available. But yeah, that's the best I can do now, and I have some other thoughts on that. Other questions?
The earlier question alluded to sort of patient derived data information, what they are looking for using the chatbots, but also there's, amongst the biggest developing tools are those that use, I see telehealth, e-health,
Right.
sort of getting community level data, real world data from people in their natural environments, feeding that back to either clinicians directly on that commercial dashboard or back into the health record. Any big picture thoughts on that?
Oh, absolutely. And you didn't, I didn't know, and you didn't know, but the very first suggestion I have for our priority is the one you just said. So clearly, and you have both sides of the street, the knowledge. One of the advantages that we have the public health school over the medical school and nursing school, not that there aren't colleagues there that get it, is the big picture and understanding. By the way, we at CFIT are spending a lot of time on telehealth and on mobile health, mHealth, and other types of non-conventional. And increasingly, by the way, at Kaiser Permanente and other organizations that are not fee-for-service, that they don't care how the doctor's paid, this is the biggest growing type of interaction. It's not medical. It's sort of a care anywhere. So yes, absolutely, getting the care where it is. And as I've mentioned, all of this information is available to Google and Facebook or Meta and XYZ, whatever his name is this week. The data are there. They use it to sell us stuff or to snoop on us. We can get data and use it for public health. Again, there's ethical issues and legal issues.
It's interesting how some people don't mind the companies getting their data, but even if it's social determinants kind of data that might be used for health purposes, there may be more reticence, which is interesting.
And you notice the second one I offered there, by the way, this slide, and I want people to potentially, if you're interested in this domain, get a hold of the slides. They'll be posted, or just send me an email. Anybody at home, I'm easy enough to find. Or you can wait till it's posted on the PHAISE site. I have some slides I haven't gotten to, but these next 7 slides are what I recommend we focus on. And we've talked about all of these issues, I think. Here's the telehealth one you just mentioned, Greg. One of the things is that we at a School of Public Health, particularly the public health interventionists, we have the classic concept of we never have enough resources. By the way, 4 or 5% of all the US resources are in public health, 95% are in medical. That's another reason that we do population health that looks at both sides. And the real savings are what we can impact the other domains. But we always think about prioritizing. How do we use AI, predictive modeling, data with a heavy whole person social aspect? How do we use that to take public health into the medical care system, into the social care system? And I don't, my premise to you is not medical school, not nursing school, maybe not social work school, certainly not business school, knows how to prioritize. And in this, the way we do in public health, because we're so poor when it comes, certainly in developing countries and even in the US. So that's my premise to you, that we can take those skills and that would allow us to take AI and data. Other thoughts before we finish up? There's also, that was the
Got a question here.
This is the negative. I'll leave this up while Tom asks his question, and we have about 4 more minutes. Again,
Yeah, thanks.
Home for one more comment. And before Tom makes his comment again, anyone that wants to continue the dialogue, I'm easy to find. And I know that PHAISE will continue its sessions as well. Tom, you may have the last word.
Yeah, not really a question, but a comment, Jonathan. One thing you didn't touch on is that doing this isn't free. And those of us who have been around as long as you and I have, we can remember back to the days you mentioned the mainframe in the basement of Rutland. We remember the days you'd run something and get a sheet at the end that told you how much it cost. Then we went to a model where we sort of outlay money to set up a technology stack that lasts us a few years, longer than a project. Now we're headed back to a model where we have to pay as we play for some of this stuff. And so it's a different way of thinking for researchers. We're fortunate at CFIT that we have the ACG stream that helps us. But researchers who don't have that, small departments, students, they now need to think about how are we going to pay for this. So that's just.
I'm really glad you mentioned that, particularly in front of the dean who will help us pay for it. Or maybe, it's joking aside, I talked about the water, the expense of cooling the machine, but these data centers are very expensive, the cloud-based centers. So I don't have an answer to that, but it's not just the human resources and the implementation resources, it's also the raw data platform resources.
I don't have a great answer nor an endless checkbook either, but I do think we need to diversify. There is incremental funding within your NIH grant if you're fortunate enough to maintain and compete in the continued flow of NIH grants. But are there philanthropic groups that want to support data resources, a named database? We can have an endowed database or designation, and then partnering with those commercial entities that may stand to benefit from your work. I think we need to do a more comprehensive and better job of putting our faculty in touch with people who could help with those aspects of funding as well.
And although I may, some people wouldn't call me cynical, but all times I make cynical comments. I'm a realist. I did make some realistic comments toward the big tech or even our computer science colleagues, but we obviously, there's no path forward without the technology companies and without computer science. And hopefully they will understand some of the value. We have to prove it for what we do. And so one of the things with some of the big initiatives out of the Whiting School is I hope we could learn from them, some of the platform techniques. And as the president thinks about the future resources, the technology platforms that Tom is talking about will have to be part of it.
I think we're going to end it there. I want those of us online, I think there was another perhaps question or two, but
email me.
Jonathan will respond on in his own time. Please join me in thanking Jonathan for taking us through a very interesting and varied journey through many aspects of AI and population health. Thanks very much, Jonathan.
Thank you for inviting me. And again, people, thank you everybody at home and here for lasting so long. My email is there. And again, these slides.
We will make these slides available on our PHAISE website, and we'll post both the recording as well as this link to the slides.
Thank you for the venue and the hosting.
Thanks very much.